Welcome everyone to the Simon's VIP MED13L virtual family meeting. And I'm going to go ahead and just pass the control over to our first presenter.
Hi everybody, thank you for having me. As I mentioned, my name is Jennifer Bain. I'm actually a pediatric neurologist, so I imagine, I don't know how that happened. I imagine you've probably seen a pediatric neurologist at one point or another during your journey, and I really appreciate the opportunity to kind of see what happens after you get the diagnosis. I know that, and I appreciate that many of you have likely had a very long journey, and I think this is a really wonderful and rare but hopefully growing opportunity for you to learn from each other remotely, and also bring that back to your individual providers, because you probably have never sat in a room with 20 other people who actually can perhaps understand a little bit more about what you're doing, more than even your providers might. So what I first need to do is thank you all, because this wouldn't be possible without you. Everything that we're going to present today is information that you've shared about your family, and that's obviously very precious information and sacred, and so we try to maintain the anonymity and really be able to put it all together and then present it back to you as a group. So I'm going to go through very basic genetic information just to kind of go through it. I think somebody earlier before was actually telling a lot more information about their genetics, and I'm sure many of you have questions about that, but we can try to go through things one at a time. Okay. Human genetics refers to the study of traits and characteristics that make up who we are. Now, interestingly, genetics can be passed down from family to family or person to person, and that's what we typically think of when we think of inheriting in genetics. And these traits and characteristics that make us who we are located in these very tiny, tiny molecules inside our body called DNA. We refer to all the genetic information that an individual has, their DNA as their genome. And we think of the genome as sort of an instruction manual or an encyclopedia to kind of building who that individual is and making one person different than the other. It makes you individual, but it also gives you the basic functions that we all need. We don't entirely understand the complexity of this human instruction manual or DNA. We also don't understand how we could be so similar and yet so different in many different ways. In the 1950s, we discovered that the structure of the human genome, and we actually understand more about how that DNA can be broken down into smaller parts, and kind of understanding how we can build these chapters of the instruction manual. We call each of these chapters in the manual a chromosome, and each person is made up of their own unique manual or own unique genome. Most people have 46 chapters in their manual and 46 chromosomes. 23 of them usually come from your mom, and 23 of them usually come from your dad. What's interesting is that even though we say something's genetic, it doesn't necessarily mean that you're passing everything along from generation to generation. And so sometimes genetic conditions might actually run in families, but they may not be inherited from your parents. For example, you could have somebody who's a healthy mom and a healthy dad, and then they have two children, one of which is healthy and doesn't have any medical problems, and the other child does have medical problems. Now, we consider this genetic, but it's not inherited. And these types of mutations or changes are called de novo, or new mutations. So they're new in that individual person. When do these de novo mutations occur? Well, it's hard to know exactly where they will occur. We know it's not in mom, it's not in dad. So somewhere in the passage from mom and dad getting together, whether that's in the egg that's actually growing, whether it's in the sperm specifically, or at or around the time of conception, or during early development, it's really hard to know. And sometimes some parts of the body can be affected, or some cells can be affected and some won't, in a situation called mosaicism, which I think is the case in some of these individuals. Unfortunately, there's not really a way to go back and find out when the actual mutation or change occurred. But what we do know is that in general, these are unlikely to be inherited into others. The recurrence risk typically is quite low, near 1% in future pregnancies. So the role of Simon's VIP is to take the information that you could provide us, put it all together, and learn more about the group as a whole. So again, none of this can actually happen without your help, so thank you. So in the Simon's VIP project, specifically with the MED13L mutation, 38 families had registered, 18 went through the first step, which was consenting and reviewing their labs by the Simon's VIP group. 12 of those 18 were considered pathogenic or problematic, is how I usually like to coin the term, or likely pathogenic. And then 7 of them, by October 8th, so a few weeks ago, were actually able to complete the medical history intake. And in that group, that's what we're going to be presenting today. There were 5 male, 2 female, and a pretty wide range from ages 3 to 27 years of age. So there are 5 others that completed the MHI since October 8th, but just so you know, they haven't been included in this information today. Okay. So you might be asking yourself, well, what is my change? What's the difference between my change and somebody else's change? Obviously, we know that there's a big spectrum of difficulties that makes each of your children very special in their own way, but we know that everybody does have a change or a variant or a problem in their MED13L gene. And what we're looking at here are all the different types of changes that you can see. If you ask me where exactly the spell checker went wrong in that chapter, we can tell you the different proteins that were affected in your individual. And so there doesn't seem to be one very specific spot in that gene that's being affected. There can be different changes in different parts of the gene, and they all seem to have the similar finding of difficulties or this neurodevelopmental syndrome that we're going to be talking about today. So what we're going to go to now is just go through little by little what common themes that we've seen in your families, perhaps to gain a little more insight as to what might be more common than others. So for example, in the newborn period, out of the 7 children that we have the full information about, we know that 3 of the children actually did have some difficulty with breathing, or called respiratory distress, during the neonatal period, and they all required oxygen. 1 of them required oxygen by a mask, and 2 actually needed to be intubated to provide them with that oxygen. 2 of them required to be put into the neonatal intensive care unit and supported that way. 1 child required phototherapy. In terms of newborn issues, we very often say that we do remember a long back time ago when the baby was very little that there were some concerns. And so looking back when these 7 children were younger, most of them do report having a poor suck, feeding difficulties. Some of them did report having a floppy or kind of loose tone, whereas 2 children did report having a stiff tone. 2 of the children were lethargic, 1 was a little more irritable, and 3 of them were reported to have hearing problems. As your children continue to grow up, we look at development. And development is really important to understand and appreciate where we should be putting our efforts in terms of caring for our children, such as therapies, etc. And for people who have younger children with the diagnosis, they very often want to know about the future. And while physicians and clinicians don't have a magic ball to predict exactly what will happen in the future, we can look at people who are older with this disorder and see what we can learn from them. So what we do see is that 7 of the children did achieve their words. And most of them did achieve them between a year and a half and 5 years of age. So children do end up gaining speech. Two children ages 3 years old were not reported to have talked just yet, but again, they're younger. So we still might have some time to kind of wait and see what happens. Similarly, many of the children do all walk. It is a little bit later than we would typically expect. 8 of the children did attain these first steps between 1.5 and 2.5 years of age. So both walking and talking are definitely feasible expectations, though it might be a little more delayed than typical development. As children grow up, we do continue to look at developmental delay, and this can be with our motor or our movements or our speech. And so in younger children, we typically use the term developmental delay. As children do grow older than 5 typically, and we start measuring their intellect, something like IQ testing or their cognitive testing, we typically will end up asking the question whether they have intellectual disability, which means that they do have weaknesses in their cognition, their thinking, as well as other skills. Out of the 7 individuals who reported their information, 4 of them have been diagnosed with autism spectrum disorder, and 5 of them have reported language disorders or speech delays. Vision problems does seem to be a problem in some of the children, not all of the children. 3 children have been reported to have strabismus or crossed eyes, perhaps even requiring glasses. Astigmatism, similar, difficulty in focusing the eyes, nearsightedness and farsightedness, and 1 child reported having ptosis or a drooping eyelid. So vision problems is certainly something that should be looked at by your general practitioner in this group of children. More often, you'll probably end up seeing someone similar to me, a neurologist, because of different neurological issues. And these neurological issues can be quite broad, such as low muscle tone. We sometimes use the word hypotonia, or high muscle tone. We'll sometimes use the word hypertonia, or spasticity, or rigidity. 1 child actually has a head size that is smaller than average, while 2 children have head sizes that are larger than average. 1 child was reportedly more clumsy, 1 with a movement disorder, and 1 with a tic disorder. Two of the 7 children have reported having seizures, 1 of which was in the setting of a fever. We typically coin that a febrile seizure in a young child, and 1 had a grand mal seizure or a generalized tonic-clonic seizure. It's not uncommon for many children with developmental concerns to have gastrointestinal issues. Similarly, in your group, 4 of the 7 children reported having problems with heartburn or gastric reflux, 2 have constipation, and 1 also reported some other GI issues. In terms of infections, we actually did see that the majority of children have required ear tubes due to multiple ear infections. This is certainly something that would be important for your provider to know about. When a child has learning difficulties and speech difficulties, it's often difficult to communicate with their caregivers whether they're in pain or whether their ears do hurt or something else is bothering them. And so it's not uncommon to, number 1, have ear infections leading to difficulty hearing, but also to not recognize that a child might have an ear infection if they're unable to communicate that with you. So certainly keeping that in the back of your mind is probably useful. Not as common in this group, but 2 children have reported having a reactive airway or asthma, whereas 1 child did report having a weak airway. In terms of kidney, urinary, and genital issues, 2 children have reported having kidney blockages and 1 had undescended testes, so not too large of a problem in this group altogether. But 2 of the children did report having difficulty with growing and gaining weight, as well as short stature. So continuing to see your general pediatrician or your general doctor to monitor your height, your weight, and your head growth are all very important part of your regular routine care. As mentioned, several of the children have had multiple ear infections that have required them to have ear tubes. Several of the children do have some vision difficulties and vision problems, such as strabismus, that sometimes does lead to the need for eye surgery. So 3 of the children needed eye surgery. 1 child needed a repair of a diaphragmatic hernia, which was likely causing some respiratory problems in the young time. And 1 child had a cyst removed from their tailbone. 1 child has been noted to have a bone abnormality called metatarsus adductus, or a pigeon toe. Allergies does not seem to be a big problem in this group of children. 1 child has animal dander and dust allergies, and 2 children have been reported to have rhinitis or runny noses or itchy noses, but in general, not a large problem in this group. And in the 5 individuals that completed the questionnaire about their medications, what we can see is that 2 children are on anti-seizure medications or anti-epileptics. 1 child is taking medication for their GI. 2 children are on medications for their breathing, like bronchodilators. 1 child is on an antidepressant, and 1 is on a growth hormone. So in general, what we can say about the individuals that have given all of their information about their medical history, their medications, and their development, we can see that children and young adults with the diagnosis of MED13L all have a developmental delay or intellectual impairments. Many have problems with language and social difficulties. Some are diagnosed with autism spectrum disorder. In the neonatal time period, we often do see neonatal issues such as respiratory distress, admission to the intensive care unit, feeding problems, as well as a poor suck. Most children, as they continue to get older, do have low muscle tone or hypotonia. Many children have vision problems and hearing problems for which they might even have surgery or require surgery. Some children have failure to thrive and short stature. A few children, though not a lot, have seizures. Some have breathing problems like asthma, some kidney issues called hydronephrosis. Again, the ear infections as well as the heartburn. And so what we can say based on the information we have here and the information in the research and clinical community is that MED13L is certainly a gene that is very important for both the development of the brain, but also the development of the body. People often say, if this is a genetic disorder, if we know exactly where the problem is in our instruction manual to life, can't we just go in there and fix the problem directly? We have different terms that we will use to describe this type of approach to addressing a genetic problem. Some people call this gene therapy, where you can provide or substitute or make up for the missing part or the dysfunctional part of the genome. Some people use the approach called genome editing, where you can go in there and snip out the problem and kind of patch up the problem exactly, since we know where the actual spell checker went wrong. And this is very interesting and important and promising in knowing that if we know exactly what's wrong with somebody's genome, we can very much personalize and individualize their therapy. And so often people say, if we know exactly where the problem is, are we there yet? And unfortunately, we're not there just yet. We're not there for most conditions. We've luckily had a lot of wonderful recent developments in the research world, especially with neurological disorders and neurodevelopmental disorders. In the last few years, we've had a lot of success with gene therapy approaches and genomic editing. But I do want to give one example, just so we don't get too too eager to see these results right now. And the example I'm going to give is a disorder called cystic fibrosis. And we know a lot about cystic fibrosis. It was actually discovered in 1989, so quite a while ago, and quite some time before the MED13L gene was diagnosed, or identified, I should say. Unfortunately, even though the gene was discovered in 1989, it took almost 25 years until a drug was even approved specifically. And importantly, cystic fibrosis is a genetic disorder, a very common genetic disorder, and we know exactly where the problem is as well. So similar to MED13L. It took 23 years in order to actually get the first drug in gene therapy for cystic fibrosis. And even that drug could only target about 4% of the patients with cystic fibrosis. The process has markedly sped up, and so the second drug was approved only a few years later. And the great news was that now this second drug is actually targeting more like 50% of children with cystic fibrosis. So this is very exciting. It's exciting for families, it's exciting for researchers, and it's a wonderful process that allows us to introduce genetic material to make up for abnormal genes or to make up for the protein that you might be missing in individuals who have this type of disorder. And genetic editing, as I mentioned, is when you actually go in there and you can precisely take out the spot that's broken and fix it with something that's more appropriate. However, we have to recognize and be appreciative that this takes a very long time. There are a lot of moving parts, and we need to be very safe and judicious about doing a lot of the research before we would go and start introducing these types of therapies in your children. So the most important thing at this point, and you're exactly doing it, is teaming up with clinicians and natural history studies such as Simon's VAP to learn mostly about your children, get as much information as we can about them, and really move the field forward. So I hope that this is informative for you, and I'm available for any questions regarding this presentation, as well as any questions perhaps related to neurology as well. Thank you very much, and I appreciate your time.
All right, great. Thank you, Jen. And before we get going on the next presentation, I'd like to give you all, 10 minutes or so to ask any questions that you might have. Like I said, you're more than welcome to just unmute yourself and chime in and ask your question, or you can chat your questions directly to me and I can read them. And if anyone doesn't have any questions, we can definitely just move on to the next presentation.
I have a question. Are we aware of any clinical trials being considered for MED13L?
This is Jen Bain speaking. I do not know of any off of the top of my head. Lindsay or Jennifer, do you know of any? If I look up clinicaltrials.gov for MED13L?
Yeah, there are none that I've seen on my radar for MED13L yet. Kelly may also be aware of them, but there's none that we've had anyone reach out to us about.
So typically what I recommend to families is there's the NIH, or the National Institute of Health, has a website called clinicaltrials.gov. And if you actually go in there and you put in your gene or your whatever disease or disorder you have, you can search. And so I just did it right now. And the only one that comes up is actually Simon's VAP because it's just online. But what I would encourage you to do is you can actually set a timer on this and a regular search with your genetic of interest. And then if anything new comes up or gets popped up onto this website, which does know about all clinical trials, mostly nationally, but some internationally, it can help you identify some of those.
And one thing I just wanted to add one more thing about, so if anyone else does hear back that they find out about another clinical trial or something, we have a gene-specific page on the Simon's VIP Connect website, and we can post other research opportunities as well, just for so that all the families are aware. Oh, sorry, what was the other question?
I have discussed this on the Facebook page with a few parents, but I still have yet to get an explanation behind how the MED13L gene affects the thyroid hormone receptor, and if because of the fact that I know in my own son I have seen so many symptoms that he displays that go along with hypothyroidism. I know that his thyroid levels are normal, but that's not to say that they are working adequately. And I was just curious if anybody here knows about the connection between the thyroid hormone receptor, given that the MED13L gene is another name for the thyroid hormone receptor, THRAP2, I believe. Does that ring a bell?
This is Lindsay from Simon's VIP, and I just wanted to chime in and say that like given the data that we are presenting on, at least, so it's mostly just 7 participants, I don't think that we have any information that's very rich regarding that, but maybe somebody else on the line might have some more information.
So I just would be curious about if there's any sort of supplementation that can be done as an experiment in helping some of these kids, if there is, well, I mean, there must be a connection there with the thyroid hormone receptor, if there was some sort of study or if anybody was looking into this. And I know it's not something that can be done right now, or we might not know the information now, but, I'm just curious if that is a pathway we could be looking into for treatment.
Yeah, I think we can definitely take that information back, because I mean, one thing that it can't be understated is that as much as you might learn from researchers and learn from the registry, we learn so much from each of you about your own experience and things that may be important to look at that researchers may not have thought of yet. So we definitely will take that comment back.
Okay, thank you. I really appreciate that so much.
I have a question about seizures, if I may. As it happens, we saw a pediatric neurologist today because our daughter, who is 9, the therapist that she was working with noticed that from time to time she seemed to blank out for sometimes a matter of seconds, and neither my wife nor I have ever noticed this before. And she had an EEG done, and it showed, I guess, what's referred to as sparks or discharges in the parietal region of the brain. And so we're now learning in real time about what we think may be absence seizures. And so if you have any guidance for us as to centers of excellence, that might be particularly aware of or related, aware of MED13L related neurological issues or seizures, we'd love to learn.
Yeah, Jen, are you still online? You might be in the best position to answer any questions, any and all questions about seizures. Lindsay, I'm wondering if we might have lost Jen, do you think?
Yeah, I'm not sure.
Oh, wait, can you hear me now?
Yes.
Yeah. We could hear you. I think we lost you again. I apologize, folks, for the technical issues.
Can you hear me now?
Yes.
Okay. Sorry, not sure. I have my other phone here. So I'll speak from the Simons information, and then I'll speak as a sidebar separate as a neurologist. So from the Simons information, again, it's very limited because we only had, I think, 7 people who replied, and only 2 of them did have seizures. So obviously our number is very low. The type of seizure you're describing, an absence seizure, which is that staring episode, is not one of the ones that's been described, but the fact that there's only 2 individuals with the very few that we're looking at, I think is not at all inconsistent. I think very commonly when we know there's been difficulties with brain development and developmental delay, you're automatically at an increased risk to somebody who had typical development to have seizures. In my mind, a seizure is an episode of immense electrical activity that goes off in the brain all at once. Depending on where the big fire goes off, in my mind, that's what you end up seeing. So if it's in the part of the brain that controls movement, then you'll see a movement. If it involves concentration, perhaps a staring episode. If it involves the vision part of the brain, you might even see something. They might see something. It's not uncommon to have episodes that are concerning for individuals for seizures. And so speaking to your doctor about that, as well as taking videos of any concerning episodes, can be really useful to show them what's happening during these episodes that are concerning. The way I think about these discharges that you mentioned, so for those of you who don't know, when we're trying to assess for seizures or look for seizures or risk for seizures, we use a test called an EEG, or an electroencephalogram. This is when you take a bunch of stickers and put them on the head on different spots, and you measure the brain activity. Sometimes it's just an hour, and sometimes it's even overnight. Sometimes it might be even overnight in the hospital. And the EEG tells you how the basic brain is working all the time, perhaps how the brain is sleeping, and what it looks for are any abnormal activity. If you had a seizure when you were on EEG, that's obviously very useful. But just because you don't have a staring episode or a seizure-like episode doesn't mean that doesn't give you a lot of information. The way I think about a seizure is if you take a match and you strike it, the fire itself is the seizure. A lot of times children might have just a spark. So the spark that could become a seizure, but not all the time. And so it sounds like your daughter might have these sparks or these electrical or epileptic discharges that could give rise to seizure or have the potential to give rise to a seizure. And that's why a neurologist will commonly either repeat EEGs or even have a discussion about medications to protect the brain from those sparks becoming a full seizure or a full flame. Does that make sense?
It does. Thank you. And are there any particular centers that you think are best for children with MED13L for this issue in particular?
I think the reality is there's not that many practitioners who are experts in this. And so even, I don't know of any what we call centers of excellence on MED13L. I encourage your group to perhaps find people who would be experts in it. But I think even if you don't have that specific expert in MED13L, if you go to a center that feels comfortable managing seizures, managing epilepsy, or even neurogenetics, so different centers do have centers where they do deal with genetic disorders. They're all wonderful clinicians who are very comfortable dealing with seizures. Most pediatric neurologists are very comfortable managing seizures, even if they don't necessarily have a personal experience in MED13L. I think most doctors don't get to see every condition that's in the books, But what they do is when they do see a patient with that, they look into the literature and see what's been published on that, and they can always connect with other doctors who perhaps might have experience.
Thank you.
Thank you. And I have a question that came in through chat, Jen. So this person was hoping you might be able to expand more on your phrasing about ending up gaining speech from the milestone section. So they're asking, like, what level of language would be considered gaining speech? Is it a few words or more than one word? Or
the way that I believe the way that we phrased the question was, do you believe that children continue to gain speech? I don't know the actual question that we used, but I think that's a really good question. Hold on, I'm going to pull it back up. So is this the slide that we're talking about? Age at first words? Language delay? I'd say based on this information, 5 out of 7 children have been reported to have speech disorders, okay? And then on top of that, we know that many of the children do gain speech, but it's later on than we would typically expect it. I'm not sure if that answers the question.
And I believe the way they summarize the data is that the questionnaire asks basically like different levels of language. So does your child speak in single words, phrase speech, that sort of thing. And I think for the summarization here, it's counting the number of individuals who at least have single words.
Thank you. And then there was a second question that came up through chat, which is, have there been any cases that reported only mild intellectual disability, or are all reported cases considered moderate to severe? So this may be a little bit trickier, but
I don't think we have that information here because Jennifer, correct me if I'm wrong, we're not providing any of the information based on mild versus moderate versus severe. We're just saying in general, the parents are reporting developmental delay.
That's true. And one thing we have tried to do in the past as well is, because it's an online study, and so we're not seeing all the children in person to be able to do different cognitive assessments. And so I think the way the data is collected right now is to get some sense of, whether there is a diagnosis of intellectual disability. But as far as the trying to categorize it into level of severity, we've tried in the past to reach out and maybe get previous medical records where those cognitive assessments were done by other providers that the families might have available, but we don't necessarily have it in our system currently.
thank you. And are there any other questions that folks have? I think we have time for maybe 1 to 2 more questions.
Yeah, I have a question. Can you hear me?
Yeah.
Going along the lines of the seizures, my son does have seizures and is currently on medication. Whenever the last guest said that his daughter is maybe having some seizures, I kind of wondered if there was a link, or if you know of any link to seizures developing during puberty, or if puberty could possibly onset seizures in kids that have developmental disabilities. And also, could kids that are developmentally delayed have earlier onset puberty? I guess that's kind of 2 questions, but I felt like that maybe they were possibly related.
So I think in regards to the seizure questions, puberty definitely can have significant changes or effects on seizures and epilepsy. Some children actually do much worse when they have puberty, whereas there's other children who actually do better and seizures go away when they hit puberty. We don't entirely understand from a medical perspective why that is. We presume it has to do with hormonal changes. I think because there's not as many people who have seizures in this group right now, we don't really know or understand the implications of that. But hopefully as your group continues to grow and gather information with time, you'll get a better understanding of whether or not there's certain time periods that a child might be at more or less at risk for having seizures. In general, we say, regardless of what the genetic disorder is, you will likely be at an increased risk for your life. There's not like one golden period that you have to get through. You unfortunately might still be at risk for many years. And then I think regarding the second question about puberty, I think it's a great question, and it goes back to the earlier question about the thyroid, and I think that probably has to do with the endocrinological problems that have been seen with some of the children. And so again, I think we don't have a lot of people to make that generalization, but certainly if there are concerns about early puberty or precocious puberty, seeing an endocrinologist to do the workup would be really important, and then coming back to the community and sharing that information would be useful for other people to say whether there's a trend with the group.
Thank you.
You're welcome.
Okay, are there any other questions before we move on to the next presentation?
Is there any way that the MED13L protein can be generated artificially or taken from other animal cells and somehow used as a supplement for the missing protein that isn't generated with these kids that have the mutations that you know, take away full functioning?
I think that kind of goes back to the questions of if we know the genetic problem, can we just substitute or make up for the genetic problem that we see? And that could be a strategy. If you're missing the protein, give it back. And that would probably go along with the clinical trials question. It doesn't look like there's anything being done right now for that. That being said, I'm not sure, and I would imagine there might be researchers out there who are doing similar types of experiments or trials in perhaps animals or other types of model organisms to study this gene. I don't know of any with humans for sure, but that's certainly something I would encourage your group to look out and see if there are researchers in the community who are doing those exact same things in what we call preclinical or perhaps animal models.
Okay, thank you very much. I appreciate your insight on that.
You're welcome.
Thank you again to Dr. Bain. We're going to go ahead and move on to the next presentation, and we'll have some time again at the end of this presentation to ask some more questions. So I'm just going to go ahead and pass it off to Barbara Hoskidler.
Good evening. Thank you so much for having me participate in this wonderful virtual family meeting. And I'm a board certified behavior analyst and special educator, and I've been in the field for many years with a particular interest in genetic changes that are underlying causes of differences in behavior and learning in children and adults. So thank you for having me here, and let me get started. So when we talk about the ABCs of behavior, Lindsay, I don't know if it's advanced, okay. What we often hear the words ABA. So we're talking about applied, meaning A is the A, B, and A. Applied means interventions are used for people in their natural settings, and the behaviors that are targeted should be important for that person's day-to-day living and their social interactions with others. Behavioral means that these interventions should be based on solid behavioral principles, and analysis means that we really try to look at what is happening, making our decisions. If the behavior is not changing in the direction we want, and go back to redesigning our program. What we'll also look at is ongoing data collection to review. I'm getting a bit of echo. All right, it's gone now, sorry.
Sorry about that, I think we got it.
Good. So ABA, though, is not just for special education, and it's not just one thing, and that's something that's very important to understand. It is more like a toolbox in which there are many, many tools. ABA is not just for schools or therapy settings, and we think about behavior management in weight control and such, or raises and incentives. They are based on positive reinforcement principles as well. Behavior is not all bad. That being said, as a behavior specialist, when I'm called into the child's school or home, oftentimes they are calling me in because there's a challenging behavior. Now, when we look at the side on the left, those are the behaviors we want to see: pointing to objects or pictures, taking an adult's hand to an item of desired, handing a picture to an adult, following directions, washing hands, reading a story. That being said, we are often working on targeting the behaviors on the right column, which would be yelling or screaming, crying, putting objects in our mouth, destroying materials, various disruptive behaviors and or aggression as well, pushing things away, running away, or just spinning up objects. Behavior, though, is caused, all right? It is observable, but not always on the, what we have to do is sometimes there are private behaviors, such as anxiety and or discomfort, but what do we see on the outside is what was observable. Now, sometimes for our children that have more communication needs and or are more delayed, we as adults or teachers and parents have to come up with what we think on the outside is the observable outside behavior that we can record and go back to that. What do we think is happening here? Then we can use it as a tool in our analysis. Behavior is communication, and that is really key. The person is doing something to let us know something. It serves a function. We have to figure out, why is the person doing this behavior? What are they getting from this behavior? The function is not usually the problem. So I always say, if you're thirsty, there's nothing wrong with being thirsty and I want a drink. But if I'm taking the water, grabbing from your glass and taking objects that don't belong to me, that would be more of the challenging behavior. Sometimes the same behavior may have several functions, such as swiping to reach something versus swiping to get, move something off the table, or swiping to watch objects fall to the ground, because I enjoy watching that, watching the objects fall. Challenging or problem behaviors really interfere with learning new skills, so that's why it's really important that we look at them. They often, in my case, especially when I go and push into schools or do consults, I'm really concerned that I don't want the student that I'm working with to be isolated from other children and or in their homes. Sometimes it's by their siblings as well. What we often talk about with board-certified behavior analysts or psychologists or the schools will often do what's called a functional behavior assessment. And that is something that what we try to do is identify and define. Usually it's a hypothesis, what we think is, we identify first the challenging or inappropriate behavior and try to describe it very specifically. But what we're trying to do is figure out what we think. Well, I think that the child is throwing himself to the ground when he is not getting access to the toy that he wants, or the child is pushing away something that they don't want to do, such as an activity, or in school sometimes it might be a specific learning project. What we try to do is identify strategies to prevent, or antecedent strategies. How can we set up this child to prevent those behaviors? And then what's really important is, if you're doing something and it works for you, then we have to come up with alternative or replacement behaviors. You don't just get rid of something. And that's something we often find as a problem if people are not taking the time to really look at both aspects of this. And then we also think about the consequences that will not maintain these behaviors. The FBA outcomes are a behavior plan, an intervention plan, a treatment plan. Often in the schools, they call it a positive behavior support plan. The strategies should be developed by a team with, if there's OT, PT, parents, the school nurse, the teachers, of course, and therapists all around this to come up with these strategies, because we want to know strategies that are going to work and are going to be implemented across. It's not just going to happen while we're sitting at a table. It's usually, throughout the day, and we want to see it across the home as well. What's very important, and I know that I spoke with Kelly prior to this call tonight in this meeting, is for many of the children I work with, we have to identify underlying medical conditions such as GI issues, discomfort because I'm constipated, some things that as a teacher, it would be helpful for me to know if these are some of the triggers or the antecedents that are underlying some of the behaviors I might be seeing on the outside of this child. Many children that are on medications, may also have some GI issues and or constipation as well. What we want to do is identify positive reinforcers, and sometimes it's a challenge. We have some children that it is very difficult to find these powerful positive reinforcers. So that's something that as a team we should work together. The environmental changes to minimize the triggers, especially if we're trying to teach a child, then what we want to do is minimize those triggers and really so that we are really setting them up to succeed when we're trying to work on teaching some skill. We want to collect some data, not too much, not too exhaustive, but some analysis, and so we can analyze and figure out if things are going well, and if they're not, let's go back to the drawing board and make some revisions. The functions of behavior, generally we think of things that we're doing things to get something. So we're doing something to get attention, to gain access to objects or an activity or something sensory. These are things that we do things to gain those things. But equally important and oftentimes underlying the function of problem or challenging behavior are escape avoidance. We want to get rid of something. For some children, they do not want attention. That doesn't seem to be the case as many of your children. But that being said, maybe they do not want certain objects or activity or some sensory input. So this escape or get rid of. When we think of the ABCs of behavior, we think antecedent, behavior, consequent, what happens first, next, and what happens after the behavior. So we think antecedents should be what happens immediately before the behavior, what might be the triggers, and could it be a person, a place, an activity, a sound, a smell, or is it a very specific demand or request? We have to also think about slow triggers and or some children don't process as quickly. I also think about in terms of, the day, as the day goes on for the student that I might, or the child, it might be in the morning, they start off fresh, and towards the end of the day, the triggers look like they're quick triggers, but really what it was the culmination of the day. What's very important, as I mentioned before, when we talk about is medical or underlying conditions, understanding if a child has seizures, has sleep issues, has toileting issues, constipation, what are the motivating operations, or what are some of these things that are very important for the child. If the child is hungry or thirsty, in pain or fatigued, these are setting events. The behavior is what we see on the outside. I mentioned that earlier, so we would identify whether it be, if it's a challenging behavior, it's swiping materials off the table, maybe aggression or grabbing at someone, grabbing the arms or sleeves, or some biting or aggression or self-biting. Consequences are what happens after the behavior, and it's important to remember consequences are not all bad. It's what happens after the behavior. Oftentimes I say we have to set the stage so our children get to the positive consequences. If they are working in a school program, they may have, the class may be having a special activity or working towards a computer time or iPad or music. There we are, consequences occur after. When we think about reinforcement, we think about things that are increasing behavior. So if reinforcement's working, it could be for some children, it's attention. For others, it could be stickers, a token system, rewards, toys or games. It could be, I had a young girl that was actually jumping on a trampoline, or one little girl liked to be squeezed. So everybody has different things that it might be reinforcers or reinforcing for the person. But what's also important is that escape and avoidance can be reinforcing. So getting rid of something or getting away from something, the way we do that behavior inadvertently, we could be reinforcing those behaviors. Reinforcers are really variable and change by, so if you're thirsty, water could be very motivating or a reinforcer for you. reinforcers change depending on what's available. So I always use this as a example. Basically, when you have mixed nuts, in the beginning, one person may like to have cashews, but when cashews are gone, then they may choose almonds, and then they may have another alternate as the different availability changes. That's something as a teacher or a therapist, oftentimes we work on the availability and working with the availability of reinforcers to really help with motivation and reinforcement. Many children, I really think that their interests are my possible reinforcers, and where they are is where I would find things that I might use to reinforce that child for the behaviors that I want to see reoccur. For some children and adults, it might be activities and exterior, going to places, going out to, sometimes for students, it's to go to an event or go to an activity in the community. That being said, I've worked with many children who have autism spectrum disorder who have some unique or unusual interests, but I feel of them as a starting place. So I had one little guy who really enjoyed ceiling fans. That was his passion. Another was string. Another was telephone poles. I mean, those are kind of obscure, but how can I take that and morph it into something that's more positive for that child? So I had one young boy that water was he really, everything was water. He enjoyed seeing water. So he didn't care for books very much. So what I did was I found a book that had the water in it, and what he would do is wait in the story, waiting for the part in the story where the water was available. So I paired the reinforcer. That's what it's called, pairing a reinforcer with another one. So punishment, I'm not necessarily a fan of punishment, but I always have to mention it because it's a consequence that happens after a behavior, and these are some of the punishment contingencies we talk about. Back on that ABCs of behavior, oftentimes, we think about those consequences, and that is what happens after the behavior. But I am, as many educators and behaviorists are, very much, interested in setting up the child for success, really looking at antecedent strategies so the person who has multiple challenges can, in fact, access the consequences, but that they can practice the appropriate behavior. Think of sometimes of prevention versus intervention. You can put up sometimes I have children that are elopers, so we need to be the gates for that child in the beginning rather than have them get injured. Sometimes we need to do that, and then gradually over time find places where we can lessen those environmental changes. Some people will say this is like you're walking on eggs. You're working on eggshells, but I feel like, for our children that have multiple, challenges, it is so important to have them achieve success. I think of myself as a behaviorist when I'm aware of the person's behavior and learning style. I feel like I'm very empowered and I'm more powerful as a behaviorist. So I can consider when I know about the child's behavior and learning styles, I am much more empowered to set them up in a good program. I think that if I'm in an antecedent strategy, I'm not worrying about as much, there's always a consequence, but what I'm looking at is I am in charge of setting up those opportunities for success. They are also less disruptive. I don't have to have the child engage in inappropriate behaviors. And it's time for acquiring skills, which is so important. And it really will help the child be more accepted by other children. And oftentimes antecedent strategies can help me because I've identified and I might be able to interrupt a behavior chain. That would be something such as, that first the child may make a protest noise, may cry. You know that potentially the next behavior may be tossing an item or standing up or throwing themselves to the floor. So when I hear that, the initial, I have an initial cue that things are going to, there's going to be a more disruptive behavior, I interrupt that, then I can engage the child in something more positive and then reinforce them for the positive behavior and try to minimize the bigger outburst or the more severe behavior issues. When I'm thinking about setting up a program or designing programs to address a child's individual needs, I often think, am I trying to teach the child a new skill, such as if they're trying to learn how to talk or use a picture exchange system. Many of your children, and that's what Kelly and I talked about, so I have a good number of slides about communication. So if I'm teaching a child to use a picture exchange versus grabbing things or biting when I need to communicate something. I might be teaching a new skill to use an iPad or a AAC, a different AAC device, or sign language. If I want to increase a behavior that the child already has, so they already do sit and attend for 1 or 2 minutes, I want to maybe increase it to a little bit longer, like 5 minutes. If I want to decrease a behavior, perseverating, I have some children and adults that would repeat over and over the same question or do not go off of a topic. So I might want to really try to decrease that behavior. There are some things that we can honor the function, and I often think, if a child is asking for a break, as long as it's not a break every 2 minutes, can we honor that? We can set up a little program that the child, that we are going to allow them so many breaks within a certain time frame. And can we honor that? If we teach that, we might want to teach that it's okay to ask for a break. I would rather you use your MAC switch to ask for a break than to get up from the table and go to the door. That being said, we have some things that we cannot honor the function. So I had many students that, of course, if there's a fire drill, we need to leave the room. We cannot, the child cannot say, no, I don't want to leave the room. We cannot honor that function. We think about ABCs of communication, that everyone needs an acceptable way to protest or request. So I think that is where many of the possible problem behaviors that may occur are, when a child doesn't have an efficient, effective means of communication. The beginnings would be to start with a comprehensive and I think a transdisciplinary assessment to look at the child's communicative intent. Of course, you would have a speech and language therapist. Many times we engage also an occupational therapist because we need to know the child's motor and or physical therapist. So many of your children may have some motor issues, so we want to figure out what is a realistic and appropriate and the best and one that the child may also, of course, would like to utilize as a form of communication. We want to set realistic goals and expectations and, start small, reinforce, really take good data, figuring out where we're going and what are realistic goals and expectations. So if you have a child that gets frustrated when he can't communicate at dinner time what he wants, let's work on some goals for some of his words around mealtime, preference of food and such. Identifying those reinforcers, and we conduct a preference assessment, and what I'd like to do with that is also have kind of look at some reinforcers are more powerful than others. So those are the ones I might want to keep less accessible, so I can be more empowered to motivate that child at times that I really want to get them to attend to a task that might be more challenging. In the beginning, though, I want to reinforce all attempts at communication with a variety of reinforcers. And some children I may really need to teach them how to learn. Basically, you don't have to have, full eye contact. Some of our children don't make as good of eye contact, but are they looking towards the speaker? Do they localize when they hear the sound of a person talking? In a classroom, sometimes I have to work because there might be instructional assistants and there are so many adults in the room. We may need to teach the child who is the person they should be accessing to communicate. And we get to this, is behavior is communication and communication is behavior. These are some strategies, and I will, you'll have handouts that I will provide to Lindsay, so I will move on to the next slide because I know we have time, we need to have some time for questions and answers as well. What's very important, I think, is the types of AAC, augmentative alternative communication systems, and we think about there are some that are called unaided. Those are ones such as facial expression or vocalization, gesture, and sign language. Sign language is a language, but it's unaided, meaning you're using what you have in your body. You're not using other devices or materials. Then we have what we call aided. So, and these are, I work with Marissa Mitchell, one of our speech and language therapists, and so she shared some of these slides with me as well, but these are some aided communication devices. So some of you may already have had some experience with them in your schools or your therapy sessions. When you think about the types of AACs, though, they go from low tech through to high tech. So low tech would be something such as a pencil and paper, alphabet boards, pictures and photos, picture exchange system as well. Then we move on to like a single message voice output. So we had a young girl who was nonverbal and, frequently was getting up from the table in a classroom and running to the door. And what we needed to do was give her a MAC switch that said, take a walk, or in the mat we could program it to say, break please. We also have some fixed display speech generating devices so that, you know, exactly what's on that device is what it's going to, and it could be programmed. And I believe some of your families may have experience with this one, but so it would have a small amount of items on the screen through to dynamic display speech generating devices that are more complex, Android like iPads. What's really important is really the match to the child, and sometimes you're going to have multiple systems depending on where the child is and for what they're accessing. What I was mentioning before about having a transdisciplinary team was important is when we've had AACs conducted here, Marissa was able to note and ask the OT to work on isolating a finger to touch the items on the board. In addition, we've had vision therapists look to say, you know, work with the team and say, this student cannot see that many items. So we really need to know it's maybe not the technology, it's the system, but also we may need to have some teaching skills ahead of time. That being said, there's some fast facts about AAC, and this picture on the right is what we've used oftentimes too, is this is actual pictures of the items that might be on a food tray. So it makes it very, for some children that may not recognize icons, it's very functional and very visible, and we can trial this and figure out quickly if a child understands by cause and effect when they touch something, that's what they're accessing. Many strategies and tools are appropriate for toddlers and preschoolers, and I know that that's a question even for myself until recently, realizing that, you know, you really don't need that many prerequisite skills in order to use some augmented or alternative devices. Many children are very quick learners about using these things. It's a matter of us figuring out what's going to be appropriate for that child. AAC's strategies do not prevent children from learning how to talk, and they provide visual supports that might aid in comprehension as well as production. So some children, you know, and also minimize some of the frustration that comes when you cannot make yourself known. But also, like I said, that if a child is struggling with some verbal vocalization, this may help with their comprehension as well as their production of speech. What we think about is also capture and contrive motivation, and that's where we behaviorists and speech and language therapists also and parents work together, is that sometimes thinking about placing a snack or a toy in a clear container with a tight lid. So dangling that carrot that it's right there and visible. Placing shoes or a jacket slightly out of reach. Now you have a reason to ask a question, or where, taking your hand to looking for something. Identifying those powerful reinforcers and limit access, I said. Providing, like at lunchtime, I don't believe you should you know, deny your child lunch. It's not the time to step back, but maybe during a snack, giving a small portion at a time, each time that they have another opportunity to request additional. During a play activity, and the child may have some familiar play activities, things that go together, then maybe just gently hold back one of the items so that's an opportunity to request. Also, sometimes it's a toy that needs new batteries. We need to find the just right fit because we do not want to frustrate. We want the child to not be frustrated, but just enough motivated to request and really reach out to us more. Learning through play. Teaching turn taking is a wonderful ability to do when you're doing it with play. When you're playing with a child, you can at times reinforce brief periods of waiting, whether it's, you know, count to 2, count to 5, we might have to start low, and then it's your turn. Reinforce looking at others, sometimes the speech therapist or will work in small groups. And if you give an item to another child, and the child will be looking towards the item, and then we want to reinforce looking at the other person as well. Reinforcing what we want to see occur again, which is requesting, my turn, your turn. I've also been a fan of doing play dates with younger children, and if we do that in the home with the family, we often want to work with the school team and say, you know, is there a child or two that in the child's class that they seem to gravitate towards each other? I've had behavior specialists come in the home and work together with the family, but what we want to do is plan and structure the activity. We want to practice communication skills. We want to practice turn taking, the just right timing. Oftentimes I found, including a snack is very helpful. Sometimes with older kids, we make a list and we do it together. So we put one thing on the list that each person wants to do before the end of that hour is over. We want something for everyone in these things. So sometimes we said, well, it's a social engineer. We had one child from school, one child from the neighborhood, and trying to reinforce, because you're teaching how to play and you're helping reinforcing the appropriate play skills. Sometimes what we're seeing when we see behavioral outbursts and with children that are not verbal and or less vocal verbal ability to express themselves is, I want it and I don't want to wait. I don't have a way to ask. I have a short attention span. It's quicker to grab for something than to ask for something. Sometimes we see, I don't think I'll ever get it back. So if I share something or another child has the toy that I wanted, I gave it to them, I don't think I'll ever get it back. Sometimes it's you don't understand what I want, and other times it's I don't understand what you want. Sometimes I don't want it, and other times I don't know how to do it. So there's all these things, and that's something that as a teacher and a therapist working with families and teams, these are the things that we try to figure out when we're looking at the function of some of the behaviors. And I look at that picture on the side, and I think of it seems sometimes it's 0 to 60. It's the end of the earth as we know it. Sometimes, but we have to try to go back and figure out where this is coming from. I think about, I always put this into strike when the iron is cold. So if I want to teach waiting during a snack, waiting or requesting, I'm not going to have a child in the middle of lunch lunch and in the school setting, or I'm not going to teach a child to get dressed as the bus is pulling up early in the morning. I might want to practice these skills, or even accepting no. I might provide like brief periods of times that at a more positive setting where I'm right there with the child and the parent. I might practice accepting limited access to something, or waiting for something, or practicing how to request for things, but striking when the iron's cold. Transition activities, these are be there for you. The transition, when you think of it, is so complicated. We can be in life, we're always transitioning. We can be from place to place, activity to activity, person to person, preferred to non-preferred, or vice versa, of all of those ways. I'm a very strong proponent of using visual schedules, any number of ways, depending on the child's level. Could be the actual items, pictures. You really need to know. I had a young child the other day that the parents are there using the picture exchange, but the parent wasn't sure if the child really understood what was in those icons that they were using. Some children don't recognize themselves in photos. We need to really step back and figure those things out before setting up the schedule. Creating jobs, sometimes we have children that we need to get them to move from A to B. We might give them a job. Can you take this to the office? Can you take this to mommy or daddy in the house? Preferred items may be used as a distractor or fidget toys, but I find that's very much on an individual basis. They can sometimes be more distracting and interruptive than actually helping move the child along. Many times, if our child understands some nonverbal cues, we can use a manual sign or point to that schedule rather than keep repeating a direction, which might be overwhelming. Some children get overwhelmed by hearing the same verbal instruction over again. Pre-specified reinforcers, that means it's like a promise reinforcer, like it's right there in front of you. We know you're going to do this. You're going to go to your cubby, or you're going to go to the other table and work with another staff. It's right there for you. Some kids, even that don't understand time, will understand that 2 minutes. And also what's important is sometimes if you have a child that really works with a visual schedule, is to make sure that they understand. Sometimes there are change-ups. So if we have in a school, maybe we have pictures of the teacher, the OT, the PT, the child may recognize and see his visual schedule of staff, but sometimes staff are absent. So we have to try to teach that as well. Timers are useful for some children. I also say what's important to say is that timers don't always signal that bad things are going to happen. Like when the timer goes off, you have to give me back your iPad, or when the timer's off, you have to do something that you don't prefer. So I always say, at home we think of timers we use that the cake is done or something. So maybe we have to think timers can be used both ways. A choice schedule I've used with some children. It's so easy to offer a choice. So in this case, I had a child that was very resistant to using the bathroom. So in a 2.5-hour segment. They were to pick and choose when they wanted to do these activities, and it was most of it was fun because I didn't want them to not want to use the schedule, so they had their choice. The real things that we were trying to get at were the child had very severe dry skin and was picking at their cuticles, and they needed to use lotion number 5, and they were not using the bathroom, so we let the child choose when within that time frame. Following directions, I'll leave these with you as well. But once again, practice sometimes with positive requests. Sometimes we don't realize that most of our requests we give children are to follow requests that are things that maybe are not preferred. For some children too, I have it here, is that allow for a possible delay in response in children, or I've had some children that initially say no because they really quite didn't understand what I was requesting. So I might wait a minute and not repeat my request and see if they then follow through. The nonverbal is often helpful. Can you help with? There's so many ways that we can offer choice or ask for, can you help me with? And some children will be very readily helpful in that way. Sometimes it's the preferred adult placing those demands or requests. We all have people within a classroom. Sometimes there's one adult that a child may prefer more for different. So if there is a preferred adult, that person might put on a request for something that's more difficult. Humor, sometimes for some children is fun. We have one little girl that we'd say, clean up your palace, princess, and she would immediately follow clean up. High probability is something we use as behavioral momentum. So it would be, if you know your child likes to play with a certain toy, you might say, bounce the ball 2 times and then do something that he may not have liked to have done. So he's practiced doing 2 things you've asked him, and then might just move on to the next. Physical structure and in the classroom, and I've had some parents even in their home because children don't often have boundaries and understand where. So even at the dinner table, I had a family with 2 children with the same condition, and they boys had very difficult time at dinner time staying away from each other's food and reaching. So what we did was we used colorful masking tape to create their little, food section at the dinner table. In the schools, we often suggest, some rug time is very difficult. Circle time, a child has low tone, is leaning on other people and is not able to sit up as well. Sometimes we've used beach chairs. Sometimes it's easier for a child to sit in a chair than to sit on the floor. But using that physical structure, you can set the child up to understand better what is expected as well during those times. Environmental, I always say when a child is in elementary, it's much easier in the classroom to see what is expected in the different areas in the room versus you get into a high school and the room is much more open-ended in the sense it doesn't have that structure to it. Schedules, getting back to some of the schedules, so the one on the left actually had the actual chapstick. It had a ball, which meant that the child was going to gym. Sneakers meant, they were going outside. So it was actual items, and they would take off actual items. I had another child that, they had needed to change, so they had the box from wipes, so they knew that meant they would take it to the bathroom as well. It also can help with transition, so a child that doesn't understand going from the classroom possibly to gym or art, so taking the actual item of a ball and bringing it to the gym, or taking the actual paintbrush and bringing it to the art room. We also talk about, in terms of behavior, we talk about many times this first then. So it could be a picture of first this, then this, and many children can learn that. It takes some time to teach it. It doesn't, like I said, it doesn't have to be with those icons. It could be with objects itself. Schedules are, this is like a routine, how to do things in what order. I find that I use actual photographs of the child engaging in the actual behavior, and it's not as, I think it's in the beginning, I might show it quite a number of times and really work on it, and then I can see if they can see it in a miniature version, or then they can have it laminated and check it off as they do each activity if I'm trying to work towards an independent skill such as washing hands. This was created with a family. I had a young boy in a pharmaceutical trial, and he really was overwhelmed. He didn't mind going to this clinical trial, but he really didn't know what was expected. And we did as the clinic and the family. So what we did was we came up with photos and like a picture schedule, and this was for one visit, and he would know to check off each of the things that he did, and then when he was all done. And one time the doctor forgot to do one of the things, and he quickly showed, he was not very verbal, vocal, but he quickly showed that the doctor missed one of the aspects of taking the vital signs. These are some of the strategies I use for decreasing verbal or physical assault, and basically what I really feel is that in this case where we talk about most times, it's some communication issues. So if you can minimize some triggers, you can recognize the signs of when the child is getting overstimulated or excited or interrupting those behavioral chains. So stepping back, and I've had teams that we talk and say, what do you notice that the child is doing that then you know next is going to be, and they're going to escalate, and be quickly, let's get in there, distract, engage, and reinforce what we want to see. Practice those good behaviors. It's not always that clear. I have to be honest. I do have students that it seems like I'm reading the story, we just had snack, everything's going well, and the child makes a noise and gets disruptive, and he doesn't seem to be comfortable in his own skin. But if we, over time, try to work as a team to figure out what sets the child up to succeed. Sometimes it has to be a neutral, no-nonsense manner when correcting a child. I often find that children are hearing our tone as well. Preferred staff in proximity oftentimes is helpful as well. These are visual supports. There would be a whole nother presentation about social stories, which basically are trying to help the child understand the perspective of what is happening. So we just did one for a young girl that needed an x-ray. So we had photos of the actual building, me greeting her. I met with the staff to find out how many x-rays she needed. And so we really, we found out things she liked. She came in telling us all about her cats, and the staff already knew that. We helped prepare her visually, rehearsing it, and that's kind of like rehearsal for her. So when she came here, she was able to get an x-ray, and it had been tried many times before, but it's that front loading. It's taking a lot of time up front to get to that success. This was one for a little girl who could not be out of the sight of her parent. Every time her mother would not be in her sight, she would, she would really have and she was nonverbal and had low tone, and as you can see, her W setting right there. But we took pictures of the family. That's her actual house, and we would play the game and put mommy in one room, daddy in another with their photos, and she did recognize them. And over time, we just kind of desensitized her that her mom could be in the house, didn't have to be in her eyesight. Barbara, you're on red was one of the, when we trying to figure out in the school, they use this system, red, yellow, green for behavior. So we mimicked it in the home to practice it, because I asked the school, what are you doing? How do you work with the child? Let's teach them at home so that we can generalize it as well. Very much important is clear, effective communication, structure, routine, and consistency. If you think of it, if you don't have a good sense of organization yourself, what helps you the most is structure, routine, and consistency. Eventually, over time of practicing the right behavior, you should become more automatic. Attention to signs of anxiety in that person's triggers. Really feel that that's very important, especially it's like, why would I put the child I'm trying to work on teaching some words or discrimination, why would I put them in an environment that was distracting as well? Attention to the language skills and the reinforces the person has. Redirection and distraction are effective. I really feel that visual supports and schedules are essential. Structuring the environment. I can do a lot of things to set up the environment to make it more conducive. Whenever possible, offering choices is something we always have available. Not too many though, so you don't overwhelm the person. Teach and offer the opportunity to request a break. Reinforce the behaviors that you want to increase, which sounds so simple, but oftentimes we sometimes have to remind ourselves of that. If it's not always what you say, but how you say it, many of our children don't have potentially the pragmatic language skills. So I often, work with teachers and say, you want to talk at the just right level for the child, not too above the child, not below them, but at their level. Controlling what you can, as I said, the environment and how you respond to behaviors. Don't underestimate the value of calm. These are some resources for you and for making visual schedules, for social stories, video modeling. I didn't mention that as much, but I've done video modeling of the child doing the appropriate behavior, because oftentimes our children don't know what we're expecting. So a picture of the child sitting at the dinner table, and I might edit out how many times they got up and walked around the room, pictures of them doing the right thing. Let's give them that feedback as well. Thank you very much. There should be time for you to ask some questions.
Yes, thank you so much, Barb, for your presentation. And again, same procedure as last time for those online. Feel free to chime in with any questions you have or send me a chat and I can read them off.
Hi, Barbara. This is Kelly Sexton.
Hi, Kelly.
Hi. I just wanted to share a personal experience with ABA therapy, and then maybe you can just add to it if you have any other professional opinions about it.
Sure.
We started ABA therapy in our home for both Dylan and Logan, and I just want to say that it was definitely a learning experience for my husband and I, because initially we thought, well, therapies are coming to the house, the boys are going to acquire new skills, it'll minimize frustration, and we just focused on the boys receiving therapy. And in fact, the therapy actually provided many strategies for my husband and I. And it was definitely a learning experience because we would have so many meltdowns, and in our home at least, we would give up. We're tired, we're frustrated. And so our therapist really pointed out to the fact that we really need to follow through with our demands. And I just wanted to share that because we are now a year in with ABA therapy at the house. I can tell you it's very challenging. It's a lot of work on both our part and the boys, but we are seeing progress with follow through. Like I said, with those demands, and we can go 45 minutes with a simple demand of washing your hands and so forth. But like I said, we are seeing progress. So I just wanted to share that because that was a learning experience for us. That it wasn't just a therapy for the boys; it was resources for my husband and I to help with the boys.
Thank you so much, Kelly, because and what's very important, though, is you need to have a good match. Like I said, don't throw out the baby with the bathwater, so to speak. I have some families that have had behaviorists that were not in alignment with their family values and their goals. That person should work with you to identify goals that are meaningful for your child in your setting, and ones that treat what they design is something that makes sense and you can utilize in your home. So I often say that, and it is very much of a learning curve. But I always say to the parents sometimes, let me shoulder this difficult incident with you. That little girl who looks so angelic. I mean, she would refuse to get out of the car she would refuse. She liked to sit in the car. She wanted the mother to continue to drive around, and it was like, after we had worked on getting her some language skills, she had some words. The one summer, the mom is like, could we work on this, because it's really exhausting. It's spending all this money on my car, my gas, and we shouldered it together, and it was a learning curve for both of us. But toilet training, another thing, sometimes it's the readiness and having someone else to help you, support you during these very challenging. And when you have two children, which it sounds like some other families do as well, that you have the other children interactions that you need almost more adults than children. So you need an extra set of arms, hands as such. So, and like I said, not all ABA is equal. So make sure you really, make sure you really feel like the person is listening to you as a parent, especially this is people in your home. It's your valuable time. It's your child's time. So make sure they're really right on board with you.
Thank you.
All right, any other questions?
Hi, this is Debbie.
Ruthie's mom.
Hi, I'd actually just love to get your input on Ruthie's ABA programming. She has been in ABA for about a year now, and they've been, originally we're taking more of a natural environment, sort of like early start approach with her, because she was young and she was 2. And I think we weren't seeing much progress. She doesn't have a lot of interfering, and well, I think it depends what you classify as an interfering behavior. She doesn't have a lot of clearly problematic behaviors. Her main interfering behavior is she likes to sit on your lap and get cuddled, which is interfering if you're trying to work face to face with her. But I think we didn't see a lot of progress with that approach. And so like we've been thinking about trying to go to more like of a discrete trial training approach, but we're struggling with like how to really get that in. Yeah.
Right. So if, how is her eye contact with you? Does she have some, you know, because many kids, you know, we know no two children are alike, but some children, even if they met the criteria, does she have any vocalizations?
So she really is nonverbal.
Okay.
She gives to request, she gives and she signs open, she signs more. She has about like 20 food signs that she uses specifically to request that, and then a few play signs.
Well, there's a few programs that, there's a pivotal response program that's based on like ABA, and it's more of looking at capturing those, what are a couple of skills that are give you the most bang for your buck, so to speak. There's also a JASPER program with parenting and to teach like joint attention to reinforce that. The other is like a verbal behavior ABA program, which is the VB map.
They were using like a PRT approach, and we've been moving towards like a VB map. Yeah, the VB map, like I said, I don't have any royalties with any of these programs, but I've been trained in most of it, you know what I mean, because of interest and but I feel that because what you're doing, if you really start at a good baseline, you really may not know what skills she has. And what Marissa would say to your daughter might be non-vocal verbal, but does she understand words? So she has a verbal understanding of words. You know, she understands open more. So those are words. Do you know what I'm saying? This may be non-vocal verbal. You know, you can have speech without communication. You can have communication without speech. So I think that communication without speech. I don't think she understands much of what we're saying, but she has ways of communicating what she wants.
Yeah, and I'd say while she's, you know, like it might be that she needs a more structured instruction, meaning that you tried the pivotal response approach, but now maybe you need to do more verbal behavior. And you know, I always think I've been in the field so many years that this is like third, fourth generation discrete trial. It's more intensive. It's much more fun. It's not as much mass trialing. And not you should have mixed and varied, lots of positive built into it. So that might be a good next route.
Okay, and like so. We were looking at sort of doing like 10 minutes like tabletop with like interspersed with still discrete trial, but more like with toys and with play. Is that sort of make sense?
If you have a therapist that's trained in that program, it's going to be embedded with play. You know, the ABLES and some of the program curriculum, there's a lot of play built into it. So it's not meant to be that you're sitting for long times, you know, working on just vocabulary. There's imitating, jump up and down, you know, clap your hands, do lots of activity as well. So so it should also be a part of a bigger curriculum. But what's nice is you're going to have data collection. You're going to see where she's going and be going towards a goal.
Okay, I think what we're running into is I think our PCBA is well trained, but the behavior techs are not always flexible.
I say that to parents sometimes, and I've even had some families that said, you know what, I would rather just have you come in for a while and work with us to get things under board first, and let's be selective. You know, I said, you need A quality staff, not C quality. I'm sorry. Do you know what I'm saying? Like, and if you have a BCBA or behaviorist that you like, then you might just say, I don't want to be just, you know, dismissive of your staff, but I really need, if I'm going to have this time, I really want it to be the quality it should be.
Okay. Okay. Thank you. That's really helpful.
Thanks. I don't want to hold up. I know I talk a lot, so I want to make sure you guys have your time as well. I know Lindsay had said you needed time for the families together too.
Yeah, but I think we probably have, you know, 7
to 10 minutes. I'm fine. I'm good. I'm good too. If there's other questions, or I'll, you know, make sure I have my email address. I mean, I can't answer very specific without seeing your children, but my email address will be on the handout that I give to Lindsay, as well.
Yeah, and just as a note, both presentation decks will be shared in PDF form with the families after the meeting, along with the recording, so everyone will still have access to all of the information that we presented today. Are there any other questions? All right, well, if anybody does think of questions after the presentation, you're of course more than welcome to email me, and I'll work to get all of those questions answered. But I think that we're all set to go ahead and stop the recording and do that now.
Thank you very much, everyone.
Thank you. That was very informative.